Good morning, everybody. It's nice to be here at Breakfast with the Chiefs. I want to thank Anton for hyping it way beyond what it should be. You know, he's a business person, so he's trying to make sure there's lots of people in the room, creating unnecessary controversy where necessary controversy prevails. But I'm delighted to be here. Customarily, when I speak at Breakfast with the Chiefs, I have a new story. This time I don't have a new story, but I have an old story because the people here are younger and they may not have heard it yet. And it's about the 4 physicians that went duck hunting. And there's an internist, a surgeon, a pathologist, and a psychiatrist. And it's cold and it's rainy and the flock of birds fly over and the psychiatrist points his gun at them and doesn't fire and sits down and says, they look like ducks, but I wonder how they feel about it. And then the internist stands up and there's another flock of birds fly over and he doesn't fire either. And he sits down and he says, well, they look like ducks, but I'm just not sure. And by this time it's cold and it's damp and it's windy and people want to get out of there. And another flock of birds fly over and the surgeon jumps up and shoots the gun 3 times and kills 3 of them. And she turns to the pathologist and says, go see if they're ducks. So usually I talk about myself for 4 or 5 minutes. I'm not going to do that. I think many of you know who I am and what I've done. I do want to spend a minute or so talking about Revera. Revera is a company that I joined as president in June of 2009. You may not know about Revera, although we're a 100% Canadian-owned company with 30,000 employees and 225 sites. We have 109 retirement sites, including Canada and the U.S., 87 long-term care sites in Canada, and 30 skilled nursing facilities in the U.S. And last year, we made a very big move into the home health care space, and now we're one of Canada's largest providers of home health care as well. So we'd like to think a little bit about being a seniors services company as opposed to either a long-term care or a retirement company or a home care company. And I'm going to leave the expert talking the answers to all the questions that were posed to Christina Bisanz, who knows way more about long-term care than I will ever know. But I do want to start with about 5 or 6 myths and realities about long-term care that I thought would be a good sort of stage setter. So the first myth about long-term care is that there are lots of residents who don't need to be there. So let's just put a few facts on the table. 100,000 residents are in long-term care in Ontario on any given year. And the average entry age in long-term care has moved from 75 to 84, which I consider to be a success of the home care business. Since 2007, there's been a 7% increase in the acuity of these residents. 73% of these residents have Alzheimer's or some form of dementia. 91% are incontinent. 77% require 1 or 2 staff to transfer in and out of bed. 89% require assistance with dressing. I can confirm that in our long-term care homes, we are seeing residents who are more frail, have a variety of complex healthcare challenges, including a substantial increase in those with dementia. Long-term care is uniquely qualified to care for these individuals. So I don't accept the myth that there are lots of people in long-term care that don't need to be there. Now, that gets to the question of waiting lists. So I've seen lots of reports that would suggest that the waiting list information, for example, the Ministry of Health's waiting list would say 25,000 people are waiting for long-term care. I think the number in waiting in Ontario hospitals are about 4,000 waiting for long-term care. And I've seen some pretty compelling arguments that with better home care and better community-based care, that some of these residents could go home and could be cared for at home, all of which I agree with. However, the difference between those people on the waiting list and those people that are actually in our residences is substantial. And for those of us who have worked in acute care for a long period of time, we always know that waiting lists are a little bit suspect. So let's just take for a moment that the fact that the waiting list information may be inaccurate does not at all suggest the people that are in long-term care shouldn't be there. The second myth I wanted to talk about is that long-term care is only a place of last resort, and life is over for you when you are admitted to long-term care. I think that many of us don't really want to talk about getting very old and getting very frail, and we don't want to think about it very much. And all of us sort of have this dream that when I'm 90, I'm going to hit my last tee shot on a bright sunny day and then keel over dead, and everybody will be very sad that I've gone so quickly. But the simple reality is that's not what happens. The simple reality is that about 10% of people that are over 85 are going to end up in long-term care facilities. And I've visited about 130 of them in the last year and a half, and I can tell you that there is no reason to be afraid of being in a long-term care facility. They are homes. We provide individual nutrition plans. We provide a broad range of recreation care. We provide individualized care services for these residents. And sure, when you go into these places, some of them are old, some of them are decrepit, but that doesn't mean that the people that are there are not being well cared for. The staff that work in long-term care facilities are dedicated, they're committed, and by and large, they deserve our respect and our understanding. They work in very difficult circumstances. So I think the reality of the fact is that long-term care is a legitimate and important part of our healthcare system, and something that we should understand can contribute more than it has contributed in the past, and Christina is going to speak to that, I think. The third myth I want to talk about is that long-term care has substantial quality and productivity issues. So let's look at the facts. Long-term care is between 97 and 100% full all the time in the province of Ontario. By and large, from a dollar per dollar perspective, it's money very well spent. Long-term care staff deliver over 111 million minutes of care every single day. And we do this with 90 to 85% satisfaction rates for all services. Now, is there a disproportionate amount of time spent on the articles and the exposés of long-term care? For sure, we have a long ways to go in some of those areas. But I don't believe that those articles represent the vast majority of care provided in long-term care. And I would quite liken it to the fact of, if you look at the 25,000 people that are suggested to be inadvertently killed in Canadian hospitals, it's not too different. If we exposed one of those every single day, people would get very nervous about going into Canadian hospitals. And sometimes these articles that talk about poor care and senior services tend to have a disproportionate reaction and negative reaction to the individuals that are there and those individuals that are doing the work. I've actually been quite impressed with the level of quality monitoring that I've seen in long-term care. I would say that it compares quite favorably to the type of quality monitoring we had at St. Michael's Hospital. We have regular board reviews of important quality measures, and more importantly, because of the rather slower numbers of admits and that type of thing, we can actually delve into specific patient issues and resident issues as they arise to try to correct those sort of circumstances. There's a long ways to go. In all human services systems, we need to strive to be a little bit better. I consider some of the challenges around utilization in long-term care not unlike, may not require hospitalizations in hospitals or average lengths of stay that are beyond where they should be. So we can be more effective in our utilization, and we obviously need to continue to build stronger quality measures. The fourth myth that I want to speak a little bit about is that long-term care is overbuilt. And for sure, it does not need to grow. And healthcare is an interesting place because there's these kind of myths that grow up around healthcare, which I think are quite interesting. So, for example, in the early 1990s, mid-1990s, when there was a commitment by the then government to build 20,000 long-term care beds, there's stories about people driving up in their car to come into their long-term care bed. I can tell you that that doesn't exist today. For certain, the people are much more frail, much more in need of care. And the simple reality is that even if you took the 25,000 people who are waiting on long-term care lists, or took the number of people that are waiting in Ontario hospitals and half that number, just took it in half, because we're going to build a much more robust and a much more strong home care system, you can just see that we still would not touch the problems that we have around long-term care capacity. I was in Calgary 2 weeks ago giving a talk to the Young Presidents Organization. I found out that in Calgary, they're opening up long-term care beds in Calgary for the first time in 9 years. And as far as I'm aware, and I might be wrong on this one, so I stand to be corrected, that the last major increase in long-term care beds that was announced was the 20,000 long-term care beds that were announced in the mid-1990s. The simple reality is that the long-term care system is undersized for its current, for the current number of seniors that we have, and will be substantially undersized unless we expand dramatically. This year, we're going to care for about 100,000 residents. By 2035, that number is projected to grow to 238,000. So more than double over the next 20 years. So the problem of capacity is very real and needs to be addressed, not on an episodic basis, but on a go-forward basis. And my view is that all governments have kind of a love-hate relationship with long-term care. They don't really want to build more long-term care beds, but they have to do it from time to time. And it's not really a glamorous part of our healthcare system, but it's an important and relevant part of our healthcare system. And ultimately, and I know in a couple of weeks Anton has got Stephen Duckett coming. One of Stephen Duckett's comments is the problems with the ER and the ALC, ER problems in Calgary and Edmonton was that they went for so long without building services in the community for seniors. The fifth myth that I want to talk about is that operating funding for long-term care is stable and is adequate. And I think it's important to understand, one of the things that I've noticed about long-term care relative to hospitals, which is quite different, is that long-term care systems are built around regulation of inputs rather than regulation of outputs. And what I mean by that is that in long-term care, most of the legislation is designed around consumer or individual protection. So that means that we regulate the inputs going into long-term care. We don't necessarily regulate the outcomes. This creates, of course, very big challenges for operators and for owners in terms of how do they manage their increasingly frail, increasingly complicated resident mix in a fixed input way. And it's a big challenge for long-term care. Some of the tools that we used actively in acute care are simply not available to us in the long-term care system, and we have to think of different ways of getting at it. And the last myth that I wanted to talk a little bit about, and this is, I think, mostly something that doesn't relate to long-term care per se, but relates to seniors and to seniors' care, is the myth is if we get this question around long-term care right, then the demands for future seniors are pretty much going to be met. And I can tell you that nothing is further from the truth. One of the real privileges that I have in my job is to travel to see different provinces, different jurisdictions, different states. I've been to 6 provinces, 10 states, not one state, not one province, and to my knowledge, neither of the countries in which Revera operates have a plan for seniors. They simply do not have a plan for it. And a plan is desperately needed because the people and the quality of the seniors that are coming forward are going to be quite different. We all know that baby boomers have changed all of those parts of the society that they've moved through. And by 2025, the youngest boomers will be 65 and the oldest will be 82, just about the age when people are going into long-term care homes. These are people who are affluent. They have 80% of the personal assets, 50% of discretionary power. They spend 77% of prescription drugs and 61% of over-the-counter medications, and 80% of all leisure travel are consumed by boomers. These are people that are going to want choices. They're going to want different types of care, and they're going to have a profound impact on how our cities function, how our hospitals function, how our long-term care facilities function, how our general society functions, and in no way, shape, or form are we prepared to deal with that particular phenomenon as it comes forward. At Revera, we support helping people remain in their homes and creating age-friendly cities, providing a range of retirement living options, and ensuring that high-quality long-term care is there for those when they need it. I'm going to stop there and turn it over to Christina and look forward to your questions. Thanks very much.
Thank you, Jeff, and thanks to all of you for your attendance and attention today. to come and listen to a topic that in my 2 years as CEO of the Ontario Long-Term Care Association has become quite a passion for me. And I have to tell you, my background is a little different because unlike most of you in this room, I'm really coming very much from a consumer advocacy perspective in my career. And while I have worked in the healthcare industry, it hasn't been from necessarily a professional standpoint. So coming into the long-term care sector has been one that certainly had piqued my interest as a consumer advocate first, and obviously as somebody who wanted to work in the sector second. And not unlike Jeff, in the 2 years that I've been here, I've certainly had very significant eye-opening in terms of the sector, the people who work in the sector, the residents who live in the sector, and the potential that the sector holds. So that potential and the promise is what I want to speak to you about today. And then hopefully we can get into some more concrete discussion around that conversation in the Q&A portion. Just a little bit about the Ontario Long-Term Care Association. We are actually the largest association representing long-term care providers in the country. OLTCA represents 2/3 of the province's not-for-profit, municipal, proprietary homes providing care, accommodation, and services to some 55,000 of the 77,000 people who live in long-term care, who are predominantly frail adults, and we also employ a similar number of staff members. As I said, I'm very pleased to be here this morning to talk about the promise and potential of the long-term care sector as a full partner in the healthcare system. Now, Jeff outlined some very common myths about long-term care, and indeed we do have some very significant challenges, not the least of which is the scope and pace of change that is occurring. Now consider, our residents are older and frailer and require a much higher level of care than even just 5 years ago. In the past year, the sector has undergone arguably the most significant transformation in its history. A new Long-Term Care Homes Act and regulations, a new compliance system, new reporting and quality improvement requirements, new resident common assessment instrument, new accountability relationship with the LHINs, and more. And all this in the space of 1 year. And not unlike many of you in this room, we are overregulated, overwhelmed, and underfunded. Fun? But with the change does come opportunity. And one of my favorite Jeff Bezos quotes is, "Frugality drives innovation just like other constraints do. One of the only ways to get out of a tight box is to invent your way out." And that is the promise of long-term care that I'd like to discuss today. Long-term care has been boxed in by public opinion, limited resources, and the myths that Jeff talked about. That's why last June, our board commissioned the Conference Board of Canada to look critically at our sector, to consult with opinion leaders and advise us on what we could do and needed to do to move forward. The Conference Board's findings were twofold. First, while conventional approaches to delivering care and service in long-term care have been adequate to date, the sector needs to find new and improved ways of operating, cooperating, funding, and delivering services to meet the increasing number of residents with higher care needs. But second, the report identified other positive reasons for the sector to pursue innovation, leading to improved health and care outcomes for residents and cost savings for the homes, the sector, and the larger healthcare system. Their recommendation to us was to develop an innovation strategy that addresses change at 3 levels: within organizations, within the long-term care sector itself, and across the system, in particular the out-of-hospital aging and care services continuum. So today I'd like to highlight 4 areas where the sector is breaking out of that box and building bench strength that we believe adds value to the healthcare system. Let's begin with putting residents first. Last year, the Change Foundation and the Ontario Association of Community Care Access Centres produced a report on transitions from hospital to the community. It identified 160 steps in hospital to long-term care process using 9 databases, 36 forms, and 15 handoffs or waits for patients. Clearly, we need to do better. For that reason, it was not surprising that over 1,200 people from the long-term care sector participated in the launch of Residents First, which is a quality improvement initiative spearheaded by the Ontario Health Quality Council and the largest initiative of its kind in Canada. The initiative focuses on key quality indicators such as falls prevention, incontinence improvement, medication management, reduction of emergency room admissions, and some other areas. It was planned that that initiative would roll out in five phases over the next 5 years. But the first phase was so oversubscribed that we now have 500 of the 630 homes in the province who are all anxious and eager to begin and be part of the Residents First initiative. Residents First uses LHIN methodology to improve care and transitions with an objective of increasing resident and family satisfaction as well as quality outcomes. The long-term care sector is arguably leading the way and setting the pace for change with this initiative. We believe that LHIN methodology could also be the answer to eliminating unnecessary steps in other parts of the continuum, such as the 160 steps that go in the transition from hospital to long-term care. Secondly, let's provide the right care in the right place at the right time. Long-term care relies on knowledgeable, caring teams, perhaps more than any other part of the healthcare system. In fact, "It takes a team to care" is the theme of our current advocacy campaign and awareness program. Last fall, the RN Journal published a great article on myths about working in long-term care. Almost all of those myths spoke to the general view that we are ill-prepared in long-term care to play a bigger role in the provision of care and services to special populations. In fact, many staff are well-trained in infection control, antibiotic therapy via IV, G-tube feeding, catheters, oxygen therapy, wound care, and end-of-life care, just to name a few. Some homes have peritoneal dialysis, convalescent care, specialized day programs, or programs that serve populations with severe mental health and addiction issues. Others offer rehabilitation and other programs that take some of the pressure off hospitals and actually get residents back into their own homes. The convalescent care program at Specialty Care Woods Park, which was one of OLTCA's 2010 Quality Team Winners of the Year, has helped over 400 people return home, exceeding both their own and ministry targets for length of stay and patient satisfaction. Another example is Shalom Village's Goldies to Home program, which supports 5 Hamilton hospital sites and 2 Hamilton convalescent care sites by providing outpatient rehabilitation and getting people out of hospital faster. The challenge is that the capacity is uneven, and there is no province-wide initiative to look at bundling and costing services that could be more effectively delivered by or located in long-term care homes. Third, let's build skills, knowledge, and expertise in the care of the aging. Long-term care homes provide excellent and largely underutilized clinical learning opportunities for students in all professions. Yet very few universities provide clinical placements in long-term care or have faculty who specialize in gerontology or are familiar with our sector. Despite the fact that the healthcare system will require many more people with specialized expertise, as Jeff indicated with the demographic changes. Over the past 6 months, OLTCA has been part of a collaborative looking at promoting productive partnerships between colleges and universities and the long-term care sector. In November, we helped to organize a day to explore the idea of establishing long-term care centers of learning, or as some might call them, long-term care teaching homes. We believe this idea has merit and models for implementation should be investigated further. We're also working with Colleges Ontario to review curricula, expand bridging programs, and develop new ways of supporting the vast and growing information needs of our sector. I should add that many of our homes are already working with their local colleges and universities. For example, Columbia Forest in Waterloo has provided placement opportunities for many of Conestoga College's PSW and RPN students. A member of the home's nursing team sits on the college's PSW Program Advisory Committee to make sure the curriculum meets the sector's evolving needs. And I'd be remiss if I also didn't discuss the potential for maximizing the role of nurse practitioners in long-term care. One study found between 39 to 43% avoided hospitalization once 3 nurse practitioners began providing service to 22 Ontario long-term care homes. There are many other examples of nurse practitioners being located on-site and having a demonstrable impact on the reduction of ER admissions, but more importantly, in terms of reducing the stress on the resident for having to go from their transition from what is ostensibly their home into ER and hospital stays. Finally, let's maximize the use of technology to ensure the sustainability of the aging care and services sector. As Clayton Christensen said, caregivers can do remarkable things as enabling technology moves from those with expertise to those with less training who can do remarkable things. The potential to achieve demonstrable cost savings, efficiencies, and improved care is significant. For example, according to the OTAC study, high-density foam mattresses reduce the incidence of new pressure ulcers by 67%. Widespread adoption of these mattresses in long-term care would prevent some 3,000 cases, resulting in an estimated savings of $17.3 million per year. The biggest barrier to using those mattresses is funding and the continued belief that's not anchored in any evidence that prevention can only occur through more resource-intensive interventions such as repositioning residents every 2 hours. But in fact, and even one of our members, Shepherd Lodge, experienced a 30% improvement in resident skin health over the sector average after employing these mattresses. Another example is Villa Marconi in Ottawa. It is using pointer-wear technology which makes computers accessible to people who have challenges, including physical or cognitive impairments or low levels of literacy. The technology allowed a resident who was suffering from depression to connect with his family and friends in Montreal, something that, according to the resident, changed his life. We need to embrace technology, particularly low-tech innovations, but we don't because of the many barriers to adoption, and in the case of long-term care, the fact that technologies very rarely address the specific needs of living and working in the sector. To that end, OLTCA has been working with MARS, colleges, research institutes, providers, and other stakeholders to create a nonprofit consortium that will give Ontario small to mid-size enterprise a central clearinghouse for their technology and aging and care service providers such as home care, long-term care, retirement, and assisted living, a mechanism for directing the development of practical solutions that will promote access to cutting-edge applied research and have a positive impact on the bottom line. Many hospitals are already doing research in assistive technologies. We'd really like to work with you to do rapid cycle testing of these technologies, develop new ones, and help bring them to market. Finally, we have a tremendous opportunity to blend technology and innovative thinking in the design of long-term care homes for the future. Currently, there is a capital renewal program, as Jeff mentioned, to redevelop some 35,000 beds that were built before the current design standards. We have a choice. We can use the same old design to have the same old long-term care facilities, or start now to look at redesign that will establish long-term care facilities as hubs of expertise and care and services for the elderly within a community, providing access not only to the residents for the care and expertise within the home, but to others who live within the community to have access to that expertise. In conclusion, these are only a few examples of the many innovative approaches occurring right here and now in long-term care. We are innovators because we have to be. We are an important part of the healthcare system because it needs us. We want to collaborate to make it more effective, more accessible, and more sustainable because it makes sense. But we can't work in isolation, and we can't operate in a box. Today, Jeff and I wanted to begin a conversation with you on the future of the aging care and services continuum. For our organization, the Conference Board of Canada report was a starting point to encourage all stakeholders to consider how we need to work together to meet the challenges ahead. OLTCA will be putting together an expert panel to explore ways to promote innovation in aging care and services, and we'll be looking to the leaders in this room and in the community, to policymakers, to researchers, to residents and families, to help us develop a vision for the healthcare sector that embraces aging care, including long-term care. Stay tuned. This is just the beginning. Thank you.
Go ahead, Camille. It's all yours.
Well, I'd like to start by thanking Jeff and Christine, but most of all for thanking Jeff, because when you're in the long-term care sector or the community sector, there's a certain kind of legitimacy you do not have. But when you have someone from the acute sector like a Jeff cross over into the dark side, it brings light.
I've been on the dark side my entire life.
So, thank you. I certainly appreciate everything that has been said. One of the questions that I have, which is a burning question that you both referenced, that is, on any given day in this province, there's a significant number of residents that are transferred to the acute care. There are a significant number that also die in acute care. And where we now have programs where we have had outreach from the hospital back into the long-term care, there is issues in terms of physicians' engagement. So I raise that question for you because even though there is time and we're doing all of that and understanding the year you've had, if we don't tackle this quickly and now, we have a huge issue.
Yeah, I think the most, I went through the questions, and this kind of relates in part to some of the questions that were pre-circulated, Camille. I mean, to me, one of the things that makes the most sense for long-term care is for long-term care to build additional capacity in end-of-life care. That, to me, makes a tremendous amount of sense. It needs to be done in a thoughtful way. It needs to be appropriately resourced, and from all particular levels. But to me, that makes the most care, the most sense. If you have a resident that's been in a long-term care facility for 2.5 years, it doesn't really make sense for that individual to go into an acute care hospital setting for the last 5 or 6 days of their lives. I mean, we should have the capacity, and we should work towards building that particular capacity. That, to me, is one of the more sensible sort of ways for us to contribute even more on a go-forward basis.
And Christina, any comment? That's the end-of-life portion, but the other section is sometimes routine care.
Yeah, and routine care. And I mentioned the nurse practitioner model within long-term care, which is limited at this point because we just don't have enough nurse practitioners. But I think the sector is certainly willing to engage in growing our own, if you will. But there's been clear evidence to support the value that the nurse practitioner on site brings to not just reducing hospital admissions, but being able to provide sort of that continuum of care, or continuum of care to the resident in the home and avoiding hospitalization. So I think it's something that we need to explore more fully and look at building the resources and capacity to do that.
So if I could push that a little longer, building that makes sense. In the meantime, we have this huge ER-ALC issue, and a significant proportion of those are folks coming from nursing homes. So to what extent can we speed that up to make life better for those residents, but also to address a larger systems issue?
Well, I think that there's other ways of, utilizing improved communication flow between, the hospital and the home, looking at ways in which things such as telemedicine can, avoid the need for a resident to be transferred to hospital, so diagnosis again could be made in the home from a distance perspective, engaging more with the physicians, and even to a degree some more education with family members who sometimes are still caught in the paradigm that that the only way that mom or dad are going to get good care is if they go to hospital and may insist on that. So it's a very complex issue and challenge that requires a many-faceted approach for solution.
The only thing I would say, Camille, is like most of these types of questions where they're beyond any organizational jurisdiction, right. It requires a dialogue by the main sort of participants in it. So it will require dialogue between the long-term care providers, the acute care providers, those people that stand in between them to get something going.
Yeah, I would probably suggest that we now have David Walker, who's leading the ER-ALC for the province, that this may be a significant issue that need to be taken up at that table, because I don't think we can wait 2 to 3 years to begin to reduce this flow of patients. Another question is, within the long-term care sector, there's a preferred accommodation, wards accommodation, and there's a mismatch. We have significantly greater number of preferred accommodation, which I understand the business sense, but we have more people in demand of the non-preferred accommodation. And so we sometimes have empty beds and people waiting. Any comment around that, or how are we going to address that going forward?
Well,
go ahead, I'll kick in.
Okay.
Take the hard part, okay? You take the hard part?
Well, I was actually going to reference one of your myths about, the whole wait list. I mean, with a 99% occupancy rate for the most part, we don't really see that a lot of those beds are going empty or staying empty for a long time. The challenge sometimes is around choice, and I think fundamentally we believe that consumers have choice. The new Act provides consumers with up to 5 choices of a home, and sometimes that process itself is what is causing a time lag for those beds to get filled. So I think we have to look at the reality is that there's not a lot of capacity that is sitting underutilized.
Yeah, I think the other thing I would say, and we happen to have this in Revera kind of at spades, is that we have A homes, which are new homes, and we have B and C homes, which are older homes. The B and C homes are the least desirable from a resident's point of view. They're the ones that have most of the standard accommodation. And the new homes, which have more of the preferred accommodation, are actually in more demand. So our older homes often find themselves at lower down on the priority list simply because they are old. So I'm not sure that I would necessarily agree that with the assertion that we need to have more standard accommodation. Well, people may want to have more accommodation they don't pay for. I think that's true.
I'll tell you where the issue is. If you're managing the wait list, as the CCACs manage the wait list in my former life, that you can have 100 people waiting on the list. What happens in reality is the 20% that can afford the preferred accommodation move quickly, where you then have the long stay in acute because they're waiting for the preferred. So as a system, we have this issue of not having enough ward accommodation in the system for the number of people who can only afford the ward accommodation. So as a system, how do we now address that issue? Because, I mean, you reference that a large number of the baby boomers are wealthy and can afford it, which is true. But there's a whole subset of the baby boomers that can't. Right. So how do we, as a sector, try and also accommodate that group of the baby boomers coming?
I think that's an excellent question, and I think I don't know if I have a great answer for it, but I would say that one of the things we need to move away from is first of all, we need to accept the fact that there are going to be a portion of those individuals who require long-term care who are not capable of paying for that particular. So we accept that as a given, right? That, however, should not be exactly the same type of response that we would give for those people who may say, I will, because I have the resource, do something different. So I think the system is probably going to diverge on that one, to be honest with you.
Yeah. And the issue there is one of the equity issue as we go forward, because I do think those of us who are privileged enough can do that, but how do we plan for those that can't as a system? And is there a role for the long-term care facilities other than just the C and D? Because I do agree with you, but so by default, you end up in the C if you can't afford versus having the same choice.
I actually think, Camille, that we actually plan from the other perspective. I actually think we plan mostly from the perspective of we're going to create something that's equitable for everyone, and so we have the floor and the ceiling are exactly the same. That's how we sort of do most of our healthcare planning, and I'm not sure that that's the way we're going to take it forward.
Yeah, no, the way I would push that is that the care the person receives should be standard across all of that, but the accommodation should vary because we all don't live in the same accommodation now. But how do we ensure the standard of care is the same?
Yeah, and I think in the standard of care, I mean, that is the given, regardless of whether you're in a 4-bed ward or a 2-bedroom or a private room. The care and you know, by regulation and so forth, we have that consistency. I think the challenge as well as we move forward is in dealing with expectations that the reality is the rate for preferred accommodation hasn't changed in 20 years. So you could be a resident in a private room in an A facility that has, you know, got all of the benefits of being built to the new design standards, and a resident in the same private room but in a C facility that is older and, you know, has some design differences, and the rate is the same. We're undertaking a redevelopment program now. We have acknowledged and identified that there is a gap between the funding that's been made available to make those redevelopments work and what would be required to be successful in redeveloping those 35,000 beds. But one of the options would be to look at raising that preferred accommodation rate. You know, would you expect to pay the same to stay in a Holiday Inn as you would the Westin? No, but there's sort of an assumption that that's the case in long-term care.
Well, you know, as you mentioned, redevelopment, and this is not an issue that I think you can solve, but, you know, give me a mic, I get to pontificate. There is an issue emerging, and it's particularly one of the urban centers, that as we go into the next round of redevelopment, the last round of redevelopment, Toronto lost 1,000 beds because the cost per footprint is the same whether you're in Wawa, Temiskaming, or Toronto. So as we go into the next round of redevelopment, can you see your members redeveloping the homes that are currently in Toronto at the footprint that's on the available from the ministry? Or are we at risk of losing even more beds from the downtown core to be redeveloped outside?
I'd say you're at risk of losing more beds. the simple answer is I'd say you're at risk of losing more beds. It's not what you wanted to hear, but that's the reality.
But so the question for me again is, how do we as a system, how do you as part of the system, how do I as part of the system work at this to prevent this from happening? Because as a planner, we can't afford 10 years from now to lose another 1,000 beds for Toronto-centric people like me who don't want to go above Lawrence.
But I think the answer, you have to get the parties in the room, because this I think the issue that you raised, Camille, is a very real one. I mean, it's a very real one, and it really does, I think, cast a pall over some of the questions that I've raised about the fact that the system has to grow, right? Because there's a fair bit of capital that has to go into the system, and you know, Toronto and urban centers have a unique sort of set of circumstances, but I think this exists throughout. I mean, there's just, you know, the capital funding models are just not robust enough to allow for the necessary expansion, in my opinion.
There's also, you know, tremendous financial implications of what we're talking about. And with the new act, for example, there's an introduction of limited licenses on long-term care homes. So it has arbitrarily limited the lifespan of a license given to a provider, whereas the lifespan of a building is 40 years. So the challenge is that even some of the financiers of the sector are kind of looking at some of the uncertainty around funding in a number of areas, notwithstanding funding to the capital development program, and saying that, you know, their risk is that much greater than it was in the past. And so that presents a challenge as well to being able to be efficient and cost effective in redeveloping or doing a greenfield new build.
Licenses issued for nowadays?
The licenses now are 25-year licenses, but that assumes that you redevelop an older home.
So we're saying we're going to have this growth in seniors. We're saying that with the growth in community care, more people are going to stay in the community longer. So it'll be frailer people that's coming into long-term care. And at the same time, we are having funding issues or capital issues to build more homes, and we are at great risk of losing homes in urban centers. I would say that's not just Toronto, that's GTA.
Right.
So, and yet we also see the condos coming, so we see more and more seniors coming back into GTA and into the downtown core. So we have a perfect storm emerging.
Not a perfect solution, but a perfect storm. Yeah, right.
Emerging.
No.
Yeah.
So I'm looking for...
Here with a microphone.
Yeah.
Any questions from the audience? I'm gonna move way over the other side. While I'm doing that, the Deputy Minister is coming on the 23rd, and he may be watching now. If not, we'll make sure he watches this, and maybe he's got some answers. So,
Just like to ask, can residents...
Somebody say we doubt it?
The question that was asked just before is that can residents choose their own doctors?
Yes, and some residents do maintain their family physician coming into a home, but in most cases, the practicality of that are challenged. So a home will have a physician, and that physician will often become the care physician for that resident.
How are they selected
How are the physicians selected?
for the home?
Well, in most cases, it's a long-standing relationship and contract for the managing physician director in a home.
How are they selected for the long-term relationship?
It's a good question. I don't know the answer to that. I don't know the answer to that question. But I can get you the answer. There's people here that know way more about it than I.
They usually apply for physicians.
They usually apply for the physician.
It's a contract and it's renewed annually.
Right.
But it does not answer the question, how are they selected after they apply? What are the qualifications required, to be more precise?
Yeah, I'm not sure. I can't answer that
We
question.
don't have that answer readily available, but we certainly will get that and make that available.
But
All right, we're gonna move on.
if I could just conclude though, but that is another one of the real challenges to the sector. There aren't enough physicians with the kind of geriatric gerontology skill set and knowledge base currently in the system to serve all of the residents that do live there.
All right, next question.
Good morning, Camille. It's good to see you back. And having worked in the community side of my career and in long-term care as well, and being a baby boomer, part of that emerging influential group, I'd like to ask what you have learned from what's happening overseas in some of the countries where they have moved to a seniors strategy that It allows the individuals, the older persons, to stay in the community that they're from or where they're located. And I think particularly looking at what baby boomers kind of envision for themselves as they age. The smaller homes, services coming to them rather than going out, because you've referred to the notion that you've got to really deal with the baby boomers' needs in this. So I wonder if you could comment on how you've been informed from what's happening across the pond on what you're envisioning if you were to build more. What would that really look like? Would it be more of what we've got now, or are you envisioning something different?
A couple of things, and I'm not sure that there's specific, Vida, from across the pond. First of all, one of the things that has struck me as I moved into this sector, right, is that it is very difficult, extremely difficult, to come up with a one-size-fits-all approach because seniors are enormously varied. And we see that mostly, for example, in our retirement communities, where some are extremely lavish and some are reasonably not lavish or Spartan. And that, that's a function of a whole lot of choices and a whole lot of, including economics. But there's a whole lot of preferences that are there. So it's very difficult to suggest that, there's kind of a one model that fits all. I like very much the notion that Christina talked about in terms of building long-term care centers that are more open to the community and less, and not only there for the residents. There's lots of suggestions that things like that are multi-level for seniors. So independent condominiums associated with assisted living, associated with long-term care, sort of this progressive sort of care. These sorts of notions seem to have attraction to some, but not to all, right? Some people, because the aging process is not a process that is necessarily even, and we don't all go through it in the same sort of way. So some people don't want to be, even though they're seniors and they're elderly, they don't want to be associated with a heavy care facility. And I saw that, for example, in New Zealand, where progressive communities of care had to work very hard to make sure that one level and the other level kind of did not interact, which is kind of contrary to what I would have thought, but that's in fact the reality. So I would say if there's 2 or 3 themes, it's a more open facilities, more engaged facilities, and more levels of care within them.
If I could just add, that's precisely the question that we want our expert panel that we've established to look at in terms of looking more globally at what are some of the examples and best practices that we could bring home, with the recognition that we already have a number of these examples in play, as Jeff said, here and now. So how can we build on those successes and take and borrow from other jurisdictions to improve on the model and the vision and strategy for the future?
And our last question represents Ontario Shores. Cheryl, the floor is yours.
Thank you. Jeff mentioned when he was talking about his myths and whatnot, he mentioned the high percentages of residents with dementia and the many regulatory changes that has come about. One of the expectations I understand is that long-term care homes are expected to have a behavioral management unit. And I'm wondering what the plan is for that, and if there's going to be some sort of standardized criteria, or if the long-term care homes are left to establish that independently.
Wow, that's a good question. I know that there is some work underway by the Alzheimer's Society to develop some of the protocols and also work within the professions to do so. And certainly through the engagement with those other stakeholders, those practices, best practices, will then be adopted through the long-term care homes as well.
Anton, I think I would just like to also encourage the rest of the healthcare sector to be active participants in the discussions around long-term care and community care. One of the big concerns I have as we go through is that we have expectations of the long-term care system without actually looking at some of the funding models. So as we have more behaviorals, etc., the expectation that existing long-term care facilities and existing funding models could meet the need of that population is problematic, because you need different construction rules, you need different sets of things, and it's a different cost structure than what currently exists. Now, the unfortunate thing, I think, is the acute care, the rest of healthcare, usually gets so focused on our issues that we don't necessarily pay attention to the community issues and the long-term care issues. So I guess I would just like to end to ask the rest of healthcare, that the rest of healthcare will fail if we don't pay attention to the community and the long-term care system and make them successful.
I just want one quick comment to your last point. I'll make a prognostication, right, which is not necessarily fact-based, but it's certainly perception-based. I visited 130 facilities in the last 18 months or so. I have never seen one memory care, whatever you call them, unit that's not completely full with waiting lists. My prognostication is that in 10 years or 15 years, we're going to be hearing way more about Alzheimer's than we hear about heart disease, right? This is a very, very big healthcare challenge, and we're nowhere near dealing with it.
So I want to especially thank Christina for, Christine for suggesting this conversation. And if we can facilitate the continuation, we've got lots of paper that we can use, and we've got lots of web space we can use, and maybe we can continue our private conversation as to how we might use it. And Jeff knows how that system works. We like good writers. So
okay. Well, I did bring a few copies of the Innovation Strategy Report. They're at the desk, but it will be available to anyone who's interested on our website. So I would really, it's a great read. I would encourage you to have a look at that.
Thank you. In recognition of their presentations today, there's a small donation going on behalf of Christina to the Ontario Nursing Home Trust, the University in Guelph on behalf of Jeff, and to the Black Coalition for AIDS Prevention for Camille. And in 3 weeks, it's the Deputy Minister in conversation with Stephen Lewis. Thank you for coming to Breakfast with the Chiefs.